Hello, everyone. Welcome to our Zoom meeting. Today, the great team will be presenting. So we will have 4 topics. I'm going to share the screen. This is the agenda for today's. So we will have 4 topics. Do we have the presenters? I'm going to hand it over to Dr. Hajer. When you are ready, Dr. Hajer, we can start. Thank you.
Yes, I think that Dr. Moayyed, I think he has the first topic.
Sounds good. I'm going to stop. And Dr. Moayyed, when you are ready, you can start. Dr. Moayyed.
Hello, doctor.
Hello. Are you ready? When you are ready, please start.
Okay. Will you can start slide now, please?
I'm sharing the screen, Dr. Moayyed. Can you see it?
Yeah, you can start the presentation.
Okay.
The show.
Good.
Okay.
Okay.
Okay, hello, my name is Dr. Moayyed Mudawi. First of all, let me thanks Dr. Nadir for giving us this opportunity. And today I will present an important topic about hypertension. And I hope I will give it in a best way. Okay. So Dr. Moayyed, can you hear me?
Yes, I can
Okay.
hear you.
Okay. Topic we'll cover today about hypertension. We will talk about epidemiology, physiological change with age, risk factors for hypertension, and classification of hypertension according to causes or blood pressure level. And we will know how to screen for hypertension and investigations and treatment. In treatment, we will talk about 3 aspects: non-pharmacological treatment, pharmacological treatment, and follow-up visit. And also we'll talk about hypertensive crisis, emergency and urgency, and finally we'll talk about resistant hypertension. Okay. According to World Health Organization, WHO, hypertension affects an estimated 1.13 billion people globally, with hypertension affecting 1 out of every 4 men and 1 out of every 5 women. Hypertension increases the risk of coronary artery disease and heart failure, and chronic kidney disease, stroke, age-related cognitive decline, and cognitive disorder. In American more than or equal 65 years, the prevalence of hypertension is 50 to 70%, highest among blacks race and higher in women than men. Doctor, can you go with me in slides? We have some technical issue here. Please, Dr. Moayyed, Hussein.
Yes, I have moved to the next
Are
slide.
you following
Do you want
me?
the next one? Yes,
Yeah,
yes.
if you can follow me just when I finish the slide, if you can, please.
Yes, I
The
have
next
changed to
slide.
the next slide.
Okay, it's first of all, it is clear with you, doctors, the voice and the picture, the presentation.
Can I
Yes.
interrupt? Dr. Moayyed Hussein, can you
Yes,
unshare the screen and then hit
all
the
right.
present view, and then you
I will
can
try. Okay, I will try. Maybe I will try to share my screen.
All right, I'll
Okay.
stop sharing.
Okay, just 1 minute.
Thank you.
You're welcome. Okay. Hello, doctor, again. Is it clear with you now?
Yes, it's clear, Moayed.
Yeah, okay. Good. I will repeat again the first slide. I talked about the epidemiology, about the WHO estimated the number of people with hypertension, and hypertension increase the risk of sort of diseases: chronic artery disease, heart failure, stroke, and chronic kidney disease, and cognitive disorders. And I said in American more than or equal 65 years, the prevalence of hypertension is 50 to 70%, highest among blacks race and higher in women than men. Excuse me. Okay, as we know, the hypertension double the risk of cardiovascular disease, stroke, peripheral arterial disease, and renal diseases. Okay, what about physiological change with age? Blood pressure increases with age, especially systolic blood pressure and pulse pressure, which is difference between systolic blood pressure and diastolic pressure. The physiological change with age increases arterial stiffness, increase in peripheral resistance, and decrease vascular compliance. Decline in baroreflex sensitivity, increase in blood pressure variability, and sympathetic nervous system activity. Heightened vasoconstriction and impaired vasodilator system. And last thing, change in kidney function and systems involved in sodium balance, and that is lead to increased salt sensitivity. What about risk factor for hypertension? As we know, there is non-modifiable and modifiable risk factor. Non-modifiable or fixed risk factor like age, positive family history for hypertension, race or ethnicity. As I said before, black people are more prone to high blood pressure. Modifiable risk factors like obesity, weight gain, and dietary sodium chloride intake, food salts, low dietary intake of calcium and potassium, also type 1 or type 2 diabetes, tobacco, alcohol consumption, psychosocial stress, and finally, physical inactivity. So, in terms of hypertension classification, we can classify hypertension by causes and by blood pressure level. Now I will start by causes. 80 to 95% of hypertensive patients are diagnosed as having primary or essential or called idiopathic hypertension. In the remaining 5 to 20% of hypertensive patients are diagnosed as having secondary hypertension. And that means there is a specific underlying disorder causing the elevation of blood pressure can be identified. And let us to see it in the next slide. Causes of secondary hypertension. One of the most important and most cause of secondary hypertension is renal diseases. As we know, like diabetic nephropathy and renovascular disease, and the most important one, renal artery stenosis, also glomerulonephritis, vasculitis, chronic pyelonephritis, and polycystic kidney diseases. Although there is endocrine disease causes like Conn's syndrome, Cushing syndrome, pheochromocytoma, acromegaly, and hyperparathyroidism. There is also other causes like aortic coarctation, pregnancy-inducing hypertension, and obesity, and also one of the most important causes of secondary hypertension, it is obstructive sleep apnea. Excessive dietary salt intake also, there is also drugs can cause hypertension like non-steroidal anti-inflammatory drugs, combined oral contraceptive pills, symptomatic drugs like or illicit stimulant like amphetamine, ecstasy, medma, and cocaine, and etc. So in clinical evaluation, you must exclude the secondary forms of hypertension first. Okay. Also, we can, as I said before, we can classify hypertension by blood pressure level and causes. And now I will start to classify blood pressure or hypertension by blood pressure level to stages. Stages of hypertension according to the recommendations published in 2017 by the American College of Cardiology and American Heart Association to 4 stages. One, elevated blood pressure, and that means when systolic blood pressure of 120 to 129, and diastolic pressure less than 80 millimeter of mercury. Okay, stage 1, when systolic pressure 130 to 139, or diastolic pressure 140, or diastolic pressure over 90 millimeter mercury, of mercury. The last stage called hypertensive crisis, with the systolic pressure more than 180 or diastolic pressure more than 120, and that requires immediate evaluation and treatment. If the systolic and diastolic pressure differ significantly, the stage is determined by the higher value. By that I mean there is 2 types called isolated systolic hypertension and isolated diastolic hypertension. Isolated systolic hypertension, when the systolic pressure is more than 130 and diastolic pressure is normal. Isolated diastolic hypertension, when the systolic blood pressure more less than 130 or normal, and the diastolic blood pressure more than 80. Okay, there are 2 well-established clinical practice guidelines on hypertension. The first one, the 2017 American College of Cardiology or American Heart Association guideline for prevention and detection and evaluation and management of high blood pressure in adults. And the second one is the recently published 2023 European Society of Hypertension, and it is guideline for the management of arterial hypertension. There is guideline similarities between the 2 guidelines, and there is differences between the 2 also. Okay, we will start by similarities between the American Heart Association and European Society of Hypertension. There is similarity in accurate blood pressure measurement. They're both agree with the 24-hour ambulatory blood pressure measurement for verifying or detecting hypertension. Also, there is similarity in cardiovascular risk calculator for treatment thresholds. They also both use the Bolt cohort equation and score E2 or BEEP that provide estimates for 10 years risk of fetal and non-fetal cardiovascular events and should be used to guide treatment decision. Also, there is similarity in initial pharmacotherapy recommendations. They both agreed in initial therapeutic choice, like include ACE inhibitors, ARABs, thiazide, diuretics and calcium channel blocker. Okay. What about the difference between these two guidelines? There is difference in hypertension definition. In American Heart, the definition of hypertension if the blood pressure more than or equal 130/80. In European Society of Hypertension, definition of hypertension when the blood pressure more than 140/90. Okay, there is also differences in normal blood pressure range or stages of our classification of blood pressure by level. Also in the hypertension blood pressure range and blood pressure target treatment for each age groups. And also there is differences between in pharmacotherapy. In European Society of Heart, blood for hypertension, blood blocker include first line therapy for hypertension. In American Heart Association, blood blockers reserve it for specific condition, including ischemic heart disease or heart failure. Before we proceed any further, I would like to say in our presentation today, we will depend mainly on 2017 American Heart Association guideline. Okay, what about screening? When to screen anyone about hypertension? Okay, adults 80 years or older with normal blood pressure should be screened once a year using office blood pressure measurement. Adults at risk of hypertension, such as obesity or previous measured systolic blood pressure more than 120 to 129, should be screened at least twice a year. There is a lot type of measurement, like we start by one, blood pressure measurement at office. Due to blood pressure variability and diagnosis require at least 3 blood pressure reading taken on 2 or 3 separate visits. Should be tested bilaterally in arms and one leg during the first visit. The patient should sit comfortably for at least 5 minutes. The blood pressure should be taken in both supine and seated positions. Patient's arm should be supported. Ensure proper cuff size. And the most important one, use the average of several readings taken at each of 2 or 3 visits. Second one, blood pressure measurement at home. It's critical to have the proper training and equipment to take precise blood pressure measurement at home. After 5 minutes of inactivity in the sitting position with a back and arm supported and leg uncrossed, patient should be advised to use an appropriate digital oscillometric system to assess blood pressure in the brachial artery and to conduct assessment in a quiet space. Over the course of a month, at least 12 to 14 measurements are needed, including morning and evening assessments. The last one and the most important measurement is 24-hour ambulatory blood pressure monitoring is the recommended approach for verifying the detection of hypertension, and also 2 sorts of types of hypertension, like white coat hypertension and also masked hypertension. Okay, ambulatory blood pressure measurement or monitoring is more reliable than office blood pressure measurement in predicting the risk of organ damage and cardiovascular disease. This is the image or picture of a man with 24-hour ambulatory blood pressure monitoring device for verifying or detecting hypertension. So, what is white coat hypertension and masked hypertension that's verified by 24-hour ambulatory blood pressure monitoring? White coat hypertension is blood pressure that is regularly elevated on office reading, but it is normal when measured by ambulatory blood pressure measurement or home blood pressure measurement or both. So what about masked hypertension? Masked hypertension, blood pressure that is normal on office readings, but it is elevated when measured by ambulatory blood pressure measurement or home blood pressure measurement. Will, what about the investigations that should I do for any patient diagnosed with hypertension? All newly diagnosed patient, the screen is appearing to you, yeah, right? Okay. All newly diagnosed patient with hypertension should have electrolytes and blood creatinine for measuring the GFR, also fasting blood glucose, urine analysis, CBC, thyroid stimulating hormone, thyroid function test, lipid profile, ECG, and the most very important one, cardiovascular system risk calculation. By that I mean we can use bullet court equation or score E2, score E2, OB provide estimates for 10 years risk of cardiovascular event. Other tests required. Okay. Other tests required albumin to creatinine ratio in certain other tests required in certain situations, like albumin to creatinine ratio in urine. Albuminuria, now considered as a separate risk for cardiovascular disease, should be evaluated in both diabetic and recent renal disease patients. Also, echocardiography is more effective than ECG in detecting the existence of hypertrophied left ventricle or hypertrophied heart failure. Okay, now how to treat. 2017 American Heart Association guideline recommendations, blood pressure target goal of less than 130 in systolic and less than 80 in diastolic. A less aggressive blood pressure goal of less than 135 systolic and 85, less than 85 diastolic for hypertensive patient in certain groups. Patient with labile blood pressure or postural hypertension, patient who are suffering from side effects to several antihypertensive drugs or medications, patient more than 75 years old experiencing a high comorbidities burden or a low diastolic blood pressure. In terms of treatment, I will start first by a non-pharmacological management. All individuals with elevated blood pressure should consider changing their lifestyle, and not every patient requires pharmacological treatment. And you must know that lifestyle modification treatment may be used alone or combined with antihypertensive medication therapy to treat hypertension. So let us to see what is the best proven non-pharmacological intervention for prevention and treatment of hypertension. First, weight loss. As you say in the slide, weight loss can decrease hypertension, systolic blood pressure by 5 millimeter of mercury. Number two, healthy diet, and the most important non-pharmacological management is DASH diet or DASH dietary pattern. Okay, consume a diet rich in fruits, vegetables, whole grains, and low-fat dietary products, and will decrease the systolic blood pressure in hypertensive patient to more than 10 or more than 11 millimeter of mercury. Also, reduce intake of dietary sodium, and also enhance intake of dietary potassium and physical activity also. And the physical activity, the most important type of physical activity is aerobic exercise. And there is also another type of exercise like dynamic resistant, isometric resistant. And the last thing, alcohol consumption. In individual who drink alcohol should reduce alcohol to, in men, less than or equal 2 drinks daily. In women, less than or equal 1 drink daily. And this will decrease the systolic blood pressure by 4 millimeter of mercury in hypertensive patient. Now, what about pharmacological management? Much of research work and guideline have concluded that the following 4 classes may be used for treating hypertensive patient. 1, diuretics, which are thiazide, like thiazide types, diuretics, significant benefit in mortality and stroke and cardiovascular event with low dose thiazide type diuretics. Number 2 is long-acting calcium channel blockers, mainly dihydropyridine types. Don't use short-acting calcium channel blocker to treat hypertensive patient, and use long-acting with low doses. Number 3, ACE inhibitors inhibit the action of enzyme that convert angiotensin to its active form. particularly advantage for these drugs to the patient with diabetes and those with heart failure. Number 4 and the last one is ARBs, angiotensin 2 receptors blocker. It's blocker for angiotensin 2 used as a first line therapy or as alternative to ACE inhibitor, especially in those with diabetes, heart failure, or microalbuminuria. An option for patient who also it's an option for patient who cannot tolerate ACE inhibitor. There is also secondary medications we can use in certain situation in hypertensive patient, like the most important one, beta blocker. Maybe first line with compelling indications like ischemic heart disease, post-MI, heart failure, okay, and so on. Also loop diuretics, preferred diuretics with symptomatic heart failure. Also potassium-sparing diuretics like amiloride. Also aldosterone antagonist like spironolactone, eplerenone. Also alpha-1 blocker. And the last thing, direct vasodilator like hydralazine, minoxidil. The new guidelines suggest that the antihypertensive therapy may be initiated in the following setting. 1, all patients with stage 2 hypertensive or hypertension, we can start the treatment with this medication. Number 2, patients with stage 1 hypertension who have one or more of the following: established atherosclerotic cardiovascular disease, diabetic patient, age more than 65 years, chronic kidney disease, or 10-year calculated atherosclerosis cardiovascular disease risk of at least 10%. You must note that in a patient with blood pressure of more than 20 millimeter of mercury systolic and 10 millimeter mercury of diastolic, combination of antihypertensive drugs from 2 different classes help in producing more profound effective against increased blood pressure than increasing the dose of a single drug, especially in Black adult. As you see here in slide, blood pressure threshold and recommendations for treatment and follow-up. According to blood pressure level classification, normal blood pressure promote just optimal lifestyle habits and reassess as I told you before in screening every 1 year. In elevated blood pressure, non-pharmacological therapy like lifestyle modification and reassess in 3 to 6 months. Stage 1 hypertensive, according to the clinical atherosclerosis cardiovascular risk or estimated cardiovascular risk, we can assess if it is more than or equal 10. We will start with a combination of non-pharmacological and blood pressure lowering medication and reassess in 1 month. If the patient, the cardiovascular risk less than 10, non-pharmacological therapy alone is enough, and reassess in 3 to 6 months. Okay. And last thing, stage 2 hypertensive. We'll start with non-pharmacological therapy and blood lowering medications, and we also reassess in 1 month. Okay. If we are reassess in 1 month, blood pressure goal meet. If yes, we reassess in 3 to 6 months. If no, assess and optimize adherence to medications. Okay. There is recommendations or recommended initial drugs classes for specific population with hypertension. Okay. General non-Black population, we will use here American Heart Association. There is also European Society of Cardiology, and also there is guideline called 8th Joint National Committee. Okay. We will focus here about American College of Cardiology or American Heart Association guideline 2017. In general non-Black population, we can initially start by ACE inhibitor or ARB or calcium channel or thiazide diuretics. In general Black population, there is no specific recommendation, but preferred to start with thiazide calcium channel blocker. Adult with diabetes, the preferred one, ACE inhibitor or ARBs. Adult with chronic kidney disease, also ACE inhibitor or ARBs plus calcium channel blocker. Heart failure with reduced ejection fraction, we can start with ACE inhibitor or ARBs or beta blocker, as I said before, or mineralocorticoid receptor antagonist or thiazide diuretics. What about hypertension in older adults? It is usually isolated systolic hypertension type. especially after age of 50. The management of hypertension in adults, weight loss and reduced salt intake is a particular beneficial in lowering blood pressure. ACE inhibitor can be used as initial monotherapy for hypertensive patient in older patients. Thiazide diuretics and calcium channel blockers is preferred. Now we'll talk about follow-up visits. Allow 4 to 6 weeks between visits. It may take up to 10 to 12 weeks for full pharmacodynamic effect after starting a medication or increasing the dose. Assess for adherence to therapy, monitor for adverse effects, especially, and the most important one, postural hypotension, measure supine and standing blood pressure, encourage self-monitoring blood pressure, also adjust dose cautiously by cautions, reinforce lifestyle modifications, evaluate for refractory hypertension or resistant hypertension. Now we'll talk about two last things. One of it's hypertensive crisis. There is two types of hypertension crisis: hypertensive urgency or hypertensive emergency. As we know, hypertension crisis, when the blood pressure systolic more than 180 and diastolic more than 120. Okay. We start by urgency. When the blood pressure is more than 180 over 120 in the absence of end target organ dysfunction. And we can treat the patient with urgency. Most can be managed with oral antihypertensive medication. What about emergency? When the blood pressure more than 180 over 120, but there is complicated by evidence of impending or progressed target organ dysfunction like heart failure, acute coronary syndrome, stroke, and etc. Okay, we can manage the patient with hypertensive emergency in hospital with continuous blood pressure monitoring. We can use parenteral administration of hypertension, IV drugs use. Do not initially target a normal blood pressure. Try to achieve 160 over 100 gradually over first 6 hours of treatment. Okay, the last thing is resistant hypertension. Is defined as systolic blood pressure more than or equal 140 or the systolic or 1 over 190 diastolic, despite the concurrent use of 3 antihypertensive drugs of different classes, including diuretics, or controlled blood pressure with more than or equal 4 antihypertensive drugs. Okay, this is the important definition for resistant hypertension, to know this patient in resistant hypertension or not. There is a causes or contributing factors to resistant hypertension, and that include undiagnosed secondary hypertension. As I said before, we must first exclude the secondary cause of hypertension. Factors related to lifestyles and diet, suboptimal choice of antihypertensive regime, certain medications, and chronic kidney diseases. How to manage patient with resistant hypertension? Managing resistant hypertension requires expertise, frequently requiring multiple antihypertensive agents. Patient must be observed and consulted regarding adverse effects, medication adherence, potential drug-to-drug interactions, and metabolic abnormalities. Infrequently, patients will require a screen for secondary causes of hypertension. Okay, we can also use treatment class options like ACE inhibitors, ARBs, and calcium channel blocker should be maximized in dose. And also ACE inhibitors and ARBs should not be used, to be cautioned in this. ACE inhibitors and ARBs should not be used together due to the risk of acute renal failure. And the last thing, there is fourth line drugs can be used in resistant hypertension is generally spironolactone or eplerenone. And that is aldosterone antagonist drugs can be used as an alternative. And you must note that it's contraindicated in patients with hyperkalemia. Okay, at the end, quick takes. Hypertension double the risk of cardiovascular disease, stroke, peripheral arterial disease, and renal disease. 24-hour ambulatory blood pressure monitoring is the recommended and the most important one to verify the detection of hypertension. Treatment of hypertension reduces the risk of cardiovascular disease events and mortality especially in older adults. According to American Heart Association guideline, blood pressure goal must be less than 130 over 80 in patients without comorbidities. Lifestyle modification treatment may be used alone or combined with antihypertensive medication therapy to treat hypertension. The last thing in our presentation today, start low and go slow. Monitor for falls and postural hypertension and other adverse events of drugs. This is the last slide. This is the resources I used: American Heart Association, American College of Cardiology, British Medical Journal, American Geriatric Society, and Family Medicine Guide in Saudi Arabia. And I hope I did better in this presentation, and I appreciate this opportunity again, and thank you.
Thank you, Dr. Moayyed.
You're welcome.
I'm Iman, the grade 1 team leader. So we will go to, I apologize for being late today due to some connection issues that I have. We will go to the next topic, that's comprehensive geriatric evaluation by Dr. Mohamed and Dr. Maali.
Good evening, everyone. This is Dr. Maali. Dr. Azhari, my colleague, and myself will gonna represent the comprehensive geriatric assessment topic today. Thank you, Dr. Nadir, for having us today. I'm gonna share my screen now. Can you see my screen now?
Not yet, Dr. Maali.
Okay, just give me a second. Can you see it now?
No, we cannot.
Not.
You cannot? Oh, okay. Just hold on. How about now? Can you see it?
Yes, now we can see it. Yes.
Okay, good. So, as I said, my colleague Dr. Azhari and myself, Dr. Mutwali, we're gonna represent the comprehensive geriatric assessment topic today. Shall we start? Bismillah. Today we will cover the WHO classification of the elderly, what is the CGA, which is the comprehensive geriatric assessment, target population, tool, models, and domains. So we're gonna start with the WHO classification of the elderly. According to the WHO, chronological old age is classified as follows. We're gonna classify them to 3 groups. First group is from 65 years old to 75 years old, defined as a young old age and a transition. They have like a transition period from working life to the retirement. The second group represent like the 75 to 85 years old, and they define advanced old age and a period where functional losses begin to be observed. The third group will be like 85 years old and older, and they define very advanced old age and period of the requires of special care and support. So this is the 3 groups according to the WHO classification. So shall we start with the comprehensive geriatric assessment, or as we can say it, CGA. So a definition, a brief definition, it's a multidisciplinary comprehensive diagnostic process designed to understand the health and functional ability and overall well-being of the elderly. We need to develop a coordinated and integrated plan for treatment and long-term follow-up. So The main two domains is the treatment and long-term follow-up for those population. Second, it's like we need to emphasize quality of life and functional status, the prognosis and outcome that entails a work of more depth and breadth. So it's like we'll concentrate mainly on the quality of life and functional status and prognosis of any hidden disease for those population. We need to employment or we need to employ of interdisciplinary teams and the use of any number of standardized instruments. So we need to emphasize or employment of like as much as we can, like from teams and from the standardized instrument and tools. It is to both diagnostic and therapeutic process. So the CGA, it's can like work for both as diagnostic and as therapeutic process or assessment. Now we need to know about the target population to do the ECG for them, and we need to know about the clinical geriatric syndrome where the CGA must be done. We're gonna start with the target population. So the target population, it's like the most critical thing here is like the target population, it's like kind of hidden population because we cannot classify them as too healthy people or too sick people. So if they are too healthy, so they cannot show up at the clinic, and if they are not too sick, we cannot catch them at the clinics too. So the problem with them, they are frail and vulnerable group. So we're gonna go with the definition of frailty first to know what is this population. So the frailty is referred to a loss of physiologic reserve that make a person susceptible to disability from minor stressors. So that means like any stress will gonna affect them. Second thing, they are an inherent vulnerability to challenge from the environment. It also means that any challenge in the environment, any stresses, any like difficult situation, it will gonna affect them. Not depend on the age, diagnosis, or functional ability, because we said they are not too sick people to know them. So frail population, they can go under old age. The female population, of course, they are like maybe more susceptible to be frail than males. To have less education, to have lower income, and to have poorer health. That's mean like to have multiple chronic diseases and to have multiple comorbidities with this disease, but again, they are not too sick to catch them. The second domain is the geriatric syndrome. There is some people have geriatric syndrome. As we said, like when you get older, you're gonna get more vulnerable to these diseases or to be like under the GCA. Multifactorial health condition. The definition of geriatric syndrome, there are multifactorial health conditions. That means it's conditions that occur when the accumulated effect of impairment in multiple systems render an older person vulnerable to situational challenge. Next thing, we need to emphasize, or it's emphasize multiple causation of unified manifestation. So the geriatric syndrome, it could be like conditions accumulated due to effect of multiple system, or the other things, it could be unified manifestation, like just one manifestation, but due to so many causations. Now we go to the tools or the tool we can use to do this assessment. They said like actually there is no assessment tools. Actual assessment tools may vary with the model, settings, or resources of the institution. So there is no actual tool that we can use it, or there is no specific tools. So it's vary with the model, setting, or resources of the institution. Another thing, there is no absolute way of doing the CGA. That's mean like there is no one way to do the CGA. So it depends on your on the situation or the health situation of the patient, on the setting that you need to do the CGA at the time, depend on the teams that you have, depend on the tools that you have. Additional tools may be triggered depending on the finding of the patient itself. As I said, it's like something that you have to modify it depend on the situation that you have. Implementation of a particular model also vary. Another thing that it could be doctor-driven versus team-driven. That means if you have one doctor, you can do it. And if you have a team, then you can do it too. One-time setting assessment versus staged assessment. That means also you can do it like at one-time visits. Then like you can catch this population during one visit and you can demonstrate it just during this visit, or you can catch them like during inpatient, maybe when you are doing research or anything like this. So it could take like stages to assess those population. To demonstrate that this can be done within 10 minutes. So you need to be very efficient so you can do it within 10 minutes. Sometimes, as I said, you can do it as a stage assessment. So that means for sure it will gonna take more than 10 minutes. So to make it easier for yourself, you can maybe print some forms and send it to the patient home or through the emails. If you cannot access the patient before the visit, then you can give them like print these forms and give it to the patient during the visit in the waiting room, so they can feel like as much as they can information. So when you start the assessment, you can be as efficient as you can. Now, what are the various models of the implementing the CGA? As I said, it's like different models. Then you can catch the patient in the inpatient while he's admitted. You can catch them outpatient, nursing home, home care, community, and research. Let's talk about the first model, the inpatient model, which is the patient that they admitted to the hospital under any other causes, like any other causes, maybe after surgery, if they have like admitted for any reason. You can have like geriatric consultation. If you are a geriatrician and had a consultation, then you can catch the vulnerable or the frail population when you are doing your consultation. If you are under geriatric assessment team, also you can catch them. If you are under the geriatric evaluation and management unit, which is called GEMUs, you can catch them, or you are under acute care elderly units too. Another model is the outpatient, which will be definitely like in the outpatient department, maybe outpatient department of geriatric consultation. Another thing is structured interdisciplinary teams. Like when you are a group of geriatrician, then you can catch, of course, the elderly people that they need to do the CGA for them. If you are nurse practitioner, if you are social worker, if you are therapist. So all of these group can do the CGA for those populations. Other models, maybe like the post-discharge and home care geriatric assessment, specialized applications, like if they are like subspecialty areas, like in an oncology department, maybe pre-operative assessment. If you are doing pre-operative assessment for anything, then you can catch them too. Post-operative assessment also, or the post-operative follow-up. Now shall we go to the main domains of the CGA? Now we're gonna leave the slides for my colleague, Dr. Azhari. Shall you proceed, Dr. Azhari?
Thank you, Dr. Mutwali. Is my voice clear?
Yes, it is.
Yes, it is clear.
Okay. Thank you, Dr. Mutwali. Hello, everyone. And thank you all for being here today. My name is Dr. Mohamed, and I will be conducting the rest of the session. Okay. So, as Dr. Mutwali said, we're talking today about the comprehensive geriatric assessment. And as any other assessment, we needed to know the definition, the goals, and the way it's usually conducted. Okay, so the definition and the goals are already covered. Now we're gonna move on to talk about the way it's usually conducted, which are the domains of the comprehensive geriatric assessment, which are basically the steps we usually do to do a thorough and comprehensive assessment. Okay, so they're basically we have like 7 to 8 steps we usually do it varies because it depends on the situation. First, we have the medical assessment, we have the nutritional assessment, the functional assessment, pharmacological assessment, psychological assessment, the cognitive assessment, and also the preventive care and health promotion. We're gonna start step by step and talk about them in depth. Okay, so first of all, we have the medical assessment, which is basically, when we talk about the medical assessment, it's called the preparation. It basically concerns with gathering relevant information and having the right people doing this. Okay, so when we say the right people, we usually talk about multidisciplinary teams. As I said before, it depends on the situation, but it's always better to conduct a comprehensive assessment by a multidisciplinary team. But what do we mean exactly by relevant information? In general, we mean by the relevant information, any information that will help us reach our goal. Specifically speaking, when we are preparing when we are preparing our medical assessment, we need to gather the medical history, the medication list, the medical records, basically those three. Okay, so it's basically we treat these patients like any other patient that reaches for a doctor. We need to take a thorough history. We need to do a very good examination. We need to know what medication they are on, and we need to know their medical records. Okay. So the third thing we need to do is laboratory and diagnostic tests, just like such as blood tests, imaging studies, and other diagnostics to identify or monitor a health condition. So that's basically the medical aspect. Next on, we have the functional assessment, which comes in two phases. So it's a primitive one and a higher one. And we usually start with the primitive one, which is the activities of daily living, which means evaluation of the ability to perform basic self-care tasks such as bathing, dressing, eating, toileting, transpiring, and continence. So those are the primitive function that we need to assess at first. When they are intact, we move on to the next step, which are the instrumental activities of daily living, or the IADLs, which is the assessment of more complex tasks needed for independent living, such as managing finances, handling transportation, shopping, preparing meals, and managing medication. And as my colleague said before, when we are doing the assessment, we can use some tools to help us conduct a very comprehensive assessment. When we are doing the functional assessment, it's always better to use a tool that's called timed up to go test, which is basically you ask the hello.
We can hear you, Dr.
Yeah, we can hear
Azhari.
you.
Okay, so as I said, we can use a tool named timed up to go test, which is basically you ask the patient to move from his chair and go, let's say, to the clinic door, for example, and then you can monitor his gait, the way he's walking, and so on. Okay. Okay. So moving on to the cognitive assessment. As we know that the geriatric patient are the most patient that we all know that the cognition most likely deteriorate with advanced age. And so it's a very important aspect to assess in the geriatric patient specifically. So we usually use a tool called cognitive function test, which are I believe you are all familiar with, which are either the mini mental state examination or the Montreal cognitive assessment, which is basically a test that assess the cognition in the patients, and it has a score. If the patient is above a certain score, then they are good to go. If they are not, then it means they have a deteriorating cognition. Also, we can screen for dementia and delirium. Again, the most susceptible patient for dementia and delirium are the geriatric patient or the elderly in general. We need to identify signs of cognitive decline or acute changes in mental status. Okay, moving on to our fourth aspect, which is psychosocial assessment, which is basically the mental health. Also, we all know that there are some relation between the old age and some diseases which are let's say which are associated with some mental diseases like depression. For example, we can take Parkinson's, which is basically a disease of elderly, and it has a very strong association with depression. So like it's very crucial to assess for the psychosocial status of the geriatric patients. We do the mental health evaluation, screen for conditions like depression, anxiety, and other mood disorders. After we do the screening, then we ask about the social support, and we ask about the quality of life, because social support may be a crucial part in let's say in making the mental health better. And the poorer the quality of life is, the poorer the mental health, of course. When we are assessing the social support, we assess for social networks, family dynamics, and support systems, which is very important. Sometimes these patients may just need someone to look after them and someone to be close to them. Also, the quality of life is very important. We evaluate for overall life satisfaction, feeling of well-being, and any social or environmental factors impacting the individual's life. So basically, we inspect for those things to locate the exact reason why those patient mental health is deteriorating. So moving on to pharmacological assessment, which again is a very important aspect, especially in the geriatric all elderly patients, because as we know, when the geriatric patient, all the elderly, are the most people with chronic comorbidities, and they basically most of them, they have polypharmacy, and it's polypharmacy is a very important issue that needs to be addressed. We need to review all medication for potential interaction, side effects, and appropriateness. We also need to look for medical adherence, which is a very important problem that usually goes under the radar, because patients' condition may be deteriorating, and most physicians would most likely forget to ask about the adherence, because it's very basic. I mean, when your condition is deteriorating, most likely one of the main issues is because you're not taking your medicine. So medication adherence is a very important thing to regularly screen for, because it usually goes under the radar. In the medication adherence, we need to evaluate for the individual's ability to manage and adhere to prescribed medications. The non-adherence causes may vary. It may be because of socioeconomic status. It may be because of poverty. It may be because of illiteracy. It may be because of a lot of reasons. So that's why it needs to be screened for. When we screen for polypharmacy, we need to use some tools. They're called START or BEER criteria, which are basically the criteria that assess for the polypharmacy, and they are crucial in eliminating or starting a drug or adding a drug to the drug regimen. Okay, so next we go and to our sixth aspect, which is nutritional assessment. Basically, we need to do the dietary review. We assess for the nutritional intake, eating habits, and potential deficiencies. As we know, geriatric patients, all elderly, they may suffer from physiological changes, just like decrease in function of their intestine, for example, and that may cause significant micronutrient and macronutrient deficiencies, and it's very common. So we need to assess for nutritional stats. We need to also do weight monitoring, because weight monitoring is very important, or very important indicator in a lot of chronic comorbidities and cancers, which are very common in the elderly group. We need to track changes in weight that could indicate health issues, just just as I said, one of the tools to assess a nutrition status is the MNA test, which is basically a nutritional assessment tool or test that has specific score. If you are above a specific score, then you are good to go. If you are under it, then maybe you are suffering from malnutrition. Okay, so going on, we need to do a preventive care and health promotion, which is a very important aspect of health. We screen for preventive services, ensuring age-appropriate screening and vaccinations are up to date. As I said before, cancers are very common in elderly and geriatric group, and so we need to do a specific screening test for the elderly group specifically. We need to do also health promotion. We need to recommend for physical activity, for prevention, and other wellness strategies, which is basically primary care steps or primary care approaches we need to do. And I want to emphasize on the fall prevention because again, falls are very common in elderly and geriatric patients. Okay. At last, those were basically the steps, but to do the steps, they are basically the plan that we need to conduct. We need to do before that care planning and coordination, which is basically they are summed in 2 points. We have individualized care plan, which is basically you need to do a tailor-made plan for each patient. We need to develop a personalized care plan based on the evaluation findings, including goals, treatment strategies, and referrals to specialists if needed. As I said, it needs to be tailor-made. Each patient is different from the other patient. We need to do coordination of care, ensuring that all aspects of the individual's care are well coordinated, including communication between primary care providers, specialists, and caregivers. Okay, so consideration when setting a plan, which I like to call like the very important approaches we need to do when we set a plan. We have 3 approaches we need to consider. First is holistic approach, which is approach that contain all the aspects, physical, mental, social well-being. It needs all to be considered because it is always better to do a holistic approach than to do things separately. And that's why the multidisciplinary team is always very important when we are conducting comprehensive geriatric assessment. The second approach is the care must be patient-centered, must be tailor-made. We involve patient, and also we need to involve the patient in the care plan. Always involve the patient in the care plan because first of all you need to gain the patient's confidence. And when you are including the patient in his care plan, they are going to trust you. You're going to establish a very good connection with the patient, and that is going to help with the outcome very significantly. Last one of the approaches is collaborative effort, and that is between you and your team. It's need to be multidisciplinary, and there must be a very good way of communication between your team, and that's going also to improve the outcome significantly. So that's all. Thank you so much for attending the presentation. If you have any question, you may proceed.
Thank you.
All right. Thank you so much, Dr. Azhari and Dr. Mutwali. We are going to go forward with our next topic, and that's going to be how to develop a blood pressure pulse mobile app in Glide app, tutorial by Dr. Moayyed and Dr. Samia. You can go ahead.
Okay, are you hearing me, guys?
Yes, we can hear you clearly.
Yeah, I'm sharing the screen. Is that clear?
Yes, we can see your screen.
Okay. So, hello everyone. Hello, Dr. Nader. My name is Dr. Samia. Today, Dr. Moayyed and I will be guiding you through the process of creating a simple blood pressure and pulse tracking application using Glide app. So we will start by showing you the basics, and then Dr. Moayyed will give you a live demonstration to bring everything together. So here is the index. So sorry. Sorry, are you hearing me, guys?
Yes, we can.
Okay. So the index will contain, so first of all, the power of mobile health, then a glide app overview, how to plan the application, setting up data structure, connecting to glide, then designing the interface, customizing and testing, then data privacy, adding advanced feature, deployment, and a conclusion. So here it's an application in a mobile phone. And before that, so the power of mobile health. So mobile health is transforming how we interact with patients and manage healthcare. Applications allow patients to track their health in real time, potentially leading to better engagement and improve outcomes. So by developing simple yet effective mobile apps, we can empower patients to take control of their health, making it easier for them to monitor vital signs like blood pressure and pulse. So here it's the logo of Glide application. What is Glide application? So it is a non-code platform, which means you don't need to be a programmer to create functional mobile applications. It offers a user-friendly interface, making it ideal for rapid prototyping. With Glide, you can transform a simple Google Sheet into a fully functional mobile application, which is perfect for those of us in healthcare looking to create practical tools quickly. So before giving the steps, so here it's planning our application. So before diving into application development, it's crucial to plan. First, define your application purpose. Who will use it and what do they need? For our blood pressure and pulse application, the target users are likely patients or healthcare providers who need to monitor vital signs. The core features should include tracking blood pressure, pulse, and the ability to add notes. We also need to consider data privacy and security as we are dealing with sensitive health information, which is an important thing. So first of all, we have to create a Google Sheet, which is the backbone of our Glide application. This is where all the data will be stored. We need to create columns for essential data points. For example, date, time, systolic blood pressure, diastolic blood pressure, pulse rate, and optional notes. So this structured Google Sheet be connected to Glide, where it will be transformed into the application interface. So here is an example of the Google Sheet. And when connecting to Glide application, so after setting up our Google Sheet, the next step is to connect it to Glide. In Glide, we create a new application and link it to our Google Sheet. Glide will automatically generate screens based on the data structure in the sheet. This connection is what allows us to turn spreadsheet data into a dynamic, interactive mobile application. And here is the pictures of the, when we go to the Glide. So we want to create a new application. We have this screen, then start with data, and we have to import the files or the Google Sheet. And here it's the next slide that we have in Glide to import the Google Sheets, and we click on continue to have the home screen. So here it's how to design the home screen of our application. So the home screen is the first thing user will see. So it needs to be clear and informative. We should display the latest blood pressure and pulse readings right on the home screen, making it easy for users to see their most recent data at a glance. We should also include buttons for adding new readings and viewing the history of previous entries. Optionally, we could add a quick access button for emergency contact. And here is an example of the home screen of our application. The next step is to build in the data entry screen, like in here, in this picture. So we can add, for example, the date, time, systolic blood pressure, diastolic, and pulse rate. So for data entry, we will create a form where users can input their blood pressure, pulse, and any notes. The form should be straightforward, with clear labels and easy-to-use input fields. It's also helpful to automate the date and time fields to reduce the chance of user error. This screen should make it simple for users to add new data accurately and quickly. So the next step is to create the data history screen, which allows user to review all past readings. We will display the data in a list format with options to filter and sort by date or value. This screen can also include charts to help users visualize trends over time, making it easier to understand their health data at a glance. And here it's an example of the history of blood pressure and pulse. So here it's how to customize the application appearance. So a well-designed application is more engaging and easier to use. We will choose a color, scheme, and font that aligns with the application purpose. Something clean and professional for a healthcare application. Adding icons and images can make the interface more intuitive. We can also customize button styles and layouts to enhance the overall user experience. So like here, we have the settings, and we can change name and icon. We can icon appearance, and you add and delete things. So here it's the final tip to testing the application. Testing is a crucial step in application development. We need to test the application on different devices to ensure it works well across both iOS and Android. This is the time to check for any errors or unexpected behavior. It's also helpful to gather feedback from potential users to identify any areas for improvement before the application goes live. So one thing that we have to emphasize is data privacy and security. So when dealing with health data, privacy and security are paramount. We must ensure that all data is encrypted and stored securely. Compliance with regulation like HIPAA in the US and GDPR in Europe is essential to protect user information and maintain trust. This step cannot be overlooked in any healthcare-related application. So here it's how to add additional features. So once the basic application is up and running, we can consider adding more advanced features. For example, integrating with wearable devices could allow automatic data collection. So we could also add modifications, reminders, symptoms tracking, and educational content, more comprehensive and useful for users. So, and here it's a picture that gives us some examples. So the final step is deployment and distribution of the app. So after the application is finalized, we can deploy it. This involves submitting the application to app stores like the Apple App Store or Google Play Store. Each platform has its own submission guidelines, so we need to follow those carefully. Once the app is live, ongoing marketing and user feedback will be essential to its success. So, and here it's the logo of the two applications. So, in conclusion, we have covered the entire process of building a blood pressure and pulse mobile app using Glide app, from planning and data structuring to designing, testing, and deployment. So I encourage you all to experiment with Glide and start building your own health application. So now I will hand it over to my colleague, Dr. Moayyed, who will present a demonstration on how to create a blood pressure and pulse tracker application using Glide app. So thank you all for your attention, and I hope you find it useful. And here are the resources that we used. Dr. Moayyed?
Hello? Hello?
Yes, Dr.
Hello,
Moayyed, we
Dr.
can hear you.
Moayad.
Okay. Oh, all right. Thank you, Dr. Samia, for the great presentation. My name is Moayyed Hussein, and I will be taking you through a live demonstration on how to create an app on Glide application. Can you see my screen? All right. Can you hear me?
Yes, we can.
All right. We will start very simple by creating the most basic app that can functions by recording the blood pressure and pulse. And then we can add more functions as we move on. This is the home screen for the Glide website. Here you can see all the information. We start by clicking on New App to create the application. We can start from the basic app. We can start from an AI generated one where we tell the website what we want to do and it will create one. We can start from any of these databases, Google Sheets, Excel, or any of the databases, or we can start from blank. And today we will start from blank to see how we can do it from blank. This is the layout or the interface of where you will be creating your application. The main tables here or the main tabs here are the data tab. This is where you will start creating any app because Glide works based on the data that you give the application. Then it will suggest how to create the app. The layout is where you will work on the layout of the application, how it looks and how it functions. And the last tab is the Actions tab. And this is a bit advanced one where you can add more actions to the application. In the Layout tab, there are many areas we want to see. This is the app's name. We can start by naming it blood pressure and pulse. And you can see that it has changed here, the name of the application. And the settings is where you can change the appearance, change the name, change the icon. We can change the icon here, make a heart icon because we are talking about the blood pressure and the pulse. And it has changed right up here in the top left corner. Now we start with the data because the data is the most important one. We add a new table, a blank table. And this is our new table. We name our new table readings. This is where we will be recording our readings. What we need is a date column, a systolic blood pressure column, diastolic blood pressure column, pulse rate column, and a comments column. So we start by editing this column to date column, and we change the type to date and time, and save. Now we add a new column from here. This is systolic. We change it to numbers because that's how we will be recording our systolic. We don't want any decimals, and that is systolic. We do the same for diastolic. Change the data type to numbers, no decimals, and that is diastolic. We want the pulse rate. Also, this will be numbers, no decimals, pulse rate. And lastly, we want comments section if the user wants to add any comments. And we go back to the layout. Here, this is a navigation. We can see the screen. This is our home screen in the app. Let's name it home screen. Home. Now, in the home screen, we can add the components that you can see it's empty here. We add components to the home screen that we can see. We start by adding a table. And this is the table here. We can see it appeared. We don't want the user. We want the source of the table to be the readings. All right. These are the readings. And we have to change the names of the tables here. This named systolic, so it can be clear what are we doing. Systolic. All right. This is the date. This is diastolic. This is the pulse rate. Now, if we add a new, this button allows us to add a new entry. You can see it shows here's the date. The systolic is 120. Diastolic is 80. Pulse is 70. And you press submit. You can see that the new reading has appeared right here. And if you go back to the data readings, you can see that the new reading has been added to this table called readings. And that's basically how the app will function, and that's the most basic form of the application. Now, if we want to add like users to the application, we will do the same things. We create a table with the users and everything. Also, we can change how we want to view the data from here, from components. Components has many things you can add to the application. You can add the profile of the person who's viewing the app. Let's see it. If we add profile. And now, if you can see here, this is the profile of the one using the app. And below it, we can see the readings from the table that he added. All right. Also, what else we can do? We can change how everything is viewed here in the tables. Like from the table reading, we are using the data from table reading. If we can change here, if we can change this to cards, list, table, it shows it like you choose the one that suits the kind of data you're showing. And for our data, table is the perfect one that it shows the day, the systolic and the diastolic and the pulse rate. All right, now moving in the components. This is just part of the layout, like it's a separator. Like if we add separator between here and here, it just like separates to make it more appealing or to leave some space for the application. Next, what we can see in the components. Now this is a bar chart. If we want to show the data in a bar, let me bring it to the top so you can see it. We choose like any component we add, we have to mention the source or tell it the source of the data we want. We want the data from readings. The chart title will be last or latest readings. All right, we want the x-axis to have the date. This is right here. Now what we want to show, we want the systolic blood pressure. Add item, we want the diastolic blood pressure. Add item, we want the pulse rate. Now you can see here it appeared immediately. This is our systolic blood pressure, our diastolic, and our pulse rate. And if you hover over the chart, you can see that systolic is 120, diastolic is 80, pulse rate is 70. And this is just another way to show the data to the user. Also, you can do lines. You have to do it all over. Sorry. Let me see what's the problem. Refresh. Yes, let's go back to the table or the chart. We want to show it in bar charts. And that's this is an app that is just barely functioning. It's not the most appealing app. In the settings, we can change the appearance of the app. We can change the color, the colors of the app. All right. We can change light mode or dark mode or leave it on auto. The background. Also in the navigation bar and tab bar. Like here, this is our navigation bar. If we add something to the menu, like let me add another screen, form screen, target table readings, create form. All right, home screen. We can see here that this is the home screen. This is the form screen, or the reading forms. We can add a reading from here too. New reading 130, 85, 80. We can make a comment. This is a comment and submit. We can see that the new data has been added immediately. And this is our tab bar, like where people can change from one screen to another screen. It's just if you want to add more functions or any more things to your application, you just add here from the navigation. You add what you want. And in the menu, like here, if we take this reading form, don't know how to. And that's
you can
basically.
just drag it.
Yes, I dragged it, but
all the way.
Yes,
Be,
yes, yes.
be,
All right. When you drag it, it shows here, right here, in the menu. Like this is the reading form. We can go back to the home. All right, and you can see that it has moved from the navigation bar below. If we duplicate it, so we can have it on both of them. Now we have it right here, and we have it right here. And this is just for users to use it the way they want the app for more accessibility. And if we want to publish the app to make it visible for everyone to use it, this is where we do it in the publish. Sorry. I think because I have a published application already, I cannot do it. Like this is where to do it. Also, we can, to make people sign into the application, we do this from here. First, privacy. We have to make the application public. It requires sign in, and anyone can create a profile. Now, this is the sign in screen that will show to people. They will enter their email address, and a PIN code will be sent to their emails, and they can log in immediately. Just the way you use the TLA Geriatric Research Fellowship app, and you can do the same thing here. And that's how to create a blood pressure and pulse tracking app. Do you have any questions?
All right, since we don't have any other questions, we can move forward to the next topic. Thank you, Dr. Moayyed and Dr. Samia. So the next topic will be how to write a letter to the editor in NEJM and JAMA. Khalid?
Hello everyone. Can you hear me?
Yes, we can.
Thank you. Okay, let me share my screen. Can you see my screen?
Yes, we can. Dr. Khalid, we're unable to hear you.
Okay, sorry for having a technical issue. Can you hear me?
Yes, we can right.
Okay, so now can you see my screen?
Yes, we can.
Okay. Hello everyone. Hello Dr. Nadir. Thank you for the opportunity. I would like also to thank the great team for giving me this opportunity. Our topic today will be how to write a letter to the editor in New England Journal of Medicine, NEJM, and the Journal of American Medical Association, JAMA. Can you hear me?
Yes, we can.
Please interrupt me if anything occurred. Okay, let's start by a definition. I promise this is going to be a little presentation of only about 15 slides. Consider it as a gift for staying this long with us in the great team. Definition: a letter to the editor is a concise and focused piece of writing that addresses issues or provide commentary on on content published in a journal, newspaper, or magazine. In the context of medical journals such as New England Journal of Medicine and the Journal of American Medical Association, this letter plays a significant role in academic discourse and scientific communication. Okay, before taking these examples, we are going to talk in general about letters to the editors. Then we are going to talk about letter to the editor in a journal. We may give example at the end of the presentation of a letter to the editor in one of the prestigious journals such as JAMA or NEJM. The purpose of letter to the editor in general: first, you are angry about something and you want others to know it. Second, you think that an issue is so important that you have to speak it out. Third, part of your group strategy to persuade others to take a specific action. You can write a letter to the editor to suggest an idea to others, to influence a public opinion, to educate the general public on a specific matter, to influence policymakers or elected officials directly or indirectly, to publicize the work of your group, and attract volunteers or program participants. So basically, when we are talking about letter to the editor, we are talking about speaking our mind. But these examples are basically when we are writing letter to the editor in newspapers. You see at the beginning of newspapers, some people write problem with the electricity, problem with floods, problem with anything. They write, they show it in the newspaper. So you are aiming for the readers of this newspaper to see the issue you are aiming them to read it. So now let's talk about the purpose of letter to the editor in journals. For example, New England Journal of Medicine and Journal of American Medical Association. Basically, when you are writing a letter to the editor in a journal, you are writing to engage with and critique a published research, offer a new insight or correct error, and contribute to scientific and clinical discourse. Letters to the editor in journal provide an opportunity to influence field, enhance your professional standing, and participate in a meaningful scholarly debate. It highlights the new evidence or perspective relevant to the recent publication. The types are from our purpose are divided into commentary, correction, and new information. The commentary one provides an information or feedback on a specific article. The correction addresses the factual inaccuracies in a published article, and the new information share additional data or insight not covered in the original article. Structure of the letter, in general, we are talking about title, the opening, the body, and the closing. Let's give a details over each one. Title. The title should be concise. It reflects the main issue or argument addressed in the letter. The opening. We are going to give an example at the end of the presentation. We are going to address all this information. The opening of the letter should be simple with formal salutation, clear, state the purpose of the letter, and reference to the specific article by title, author, and publication date. Sorry, let me check. Can you hear me?
Yes, we can.
Okay, thank you. Is the presentation clear?
Yes.
Okay, thank you. The body consists of introduction, main content, and conclusion. The introduction is a brief summary of the article and its main finding. So you are going to critique the article. You start with mentioning the article and what are the content of the article. Then the main content of the body should present your critique or additional information depending on the type of the letter you are writing. It should be, and you should be, clear, quick, concise, and quiet throughout the letter. You should focus on one point at a time and one main issue or point. Support your point with evidence. Don't just give your critique. You should support it with evidence or data. State your opinion about what should be done. Don't just comment. You should give your opinion of how to get over this problem. Conclusion, you should summarize your main argument or insight and suggest a potential impaction or further research. The closing of the letter should include a polite closing statement. It should include the contact information and any relevant affiliation if required. Okay, how do you get your letter accepted? You are writing a letter, you are submitting the letter, and you want the letter to be accepted. There are some points you should focus on. First, you should follow the submission guidelines. For most of journals, the submission guidelines states that the word limit is about 300 words. Let's say it's in abstract size. For some journals, it specifies, for example, some journals, the limited extent is to 400. For some journals, it's about 200. So it varies. You should return to the journal guidelines before writing your letter. You should follow the structure or format in the submission method. Also, you should follow the format, starting with what, followed by what, conclusion, affiliation, how to greet, how to do anything. Should be in the format and you should follow it. You should craft a clear and relevant letter. Should be relevant to the journal objective if it's not related to an article. If it's related to an article, some journals specifies that the article should be published in the previous 4 or 3 weeks. You should follow and write a relevant letter. You should be constructive and professional. Even if you want to critique a published article, you should be polite and start with complimenting the article and being professional in your criticism. Maintain a respectful and professional tone and support your point with evidence or well-reasoned arguments. Issue originality. You can't copy and paste another letter. You should check for accuracy of your letter. Okay, here is an example of a letter to the editor. We are going to mention the points we mentioned earlier with each section of this example. First, I talked about the title, that it should be concise and addressing the main issue. Here is the title, response to. The title of the article that we are going to critique is the efficacy of new antihypertensive agent in reducing cardiovascular events. So the title is short. It's addressing what is the content of the letter. The content of the letter is a response to this article with the name efficacy of new antihypertensive agents in reducing cardiovascular events. Dear editors, start with simple salutation in the opening. Here, dear editors, it's a simple salutation. The opening also should include the main issue we are going to talk about in the letter. I read with great interest the recent article by Smith et al. July 15, 2014 issue on the efficacy of the new antihypertensive agent, hypertenol, in reducing cardiovascular event in patient with stage 2 hypertension. Well, he stated in his opening that he read the article, so the main issue point we are going to talk about is this article, criticizing or complimenting or commenting on it. We are going to start then with the body of the letter. The body of the letter start with the introduction. The introduction should include main points of the article. So he started. The study is robust design and significant finding provide valuable insight into the management of hypertension. He started with complementing the article. He's been professional in that and giving the main points of the article. However, I would like to raise few points regarding the study's methodology and interpretation of the results. He concluded his introduction by giving the main points that he is going to talk about through the letter. Then let's go to the main content of the letter. Firstly, the study reported a 25% reduction in cardiovascular events with hypertenol compared to the placebo group. While it is substantial finding, the subgroup analysis represented in the supplementary material raises some concerns, specifically the subgroup of patient age 65 and older showed a less pronounced benefit, 12% reduction, compared to the overall cohort. Then he gave his critique and he mentioned the evidence by data, the data of the people aged 65 and older. He mentioned that they have been given a less reduction in blood pressure compared to the overall cohort. This discrepancy warrants further exploration. Then he gave his opinion about what should be done. Further exploration, as older patients are often at higher risk of cardiovascular events and may respond differently to antihypertensive therapies. Secondly, the study utilized the new biomarker CardioPredict-1 to measure the cardiovascular risk. While this biomarker show promise, the long-term predictive value of CardioPredict remain uncertain. A longer follow-up period and additional validation studies are needed to confirm its utility in routine clinical practice. In conclusion, then here he finished his main body. He went to the conclusion. While the finding of Smith et al. Are promising, further research, his opinion, is needed to address the different effects observed in older adults and to validate the new biomarker used in the study. These additional insights could enhance the applicancy of hypertenol in diverse patients. Population and continue to more personalized treatment approaches. Thank you for considering these points. He ended the letter in a polite way. He suggested to do further researches, and he concluded with his signature, sincerely, Jane Don, MD, Department of Cardiology, City Hospital, email. The key elements in the example, as we said earlier, title reflects the main topic or issue addressed in the letter. The opening addresses the editor and reference to the specific article with its title and publication date. The body introduction briefly summarizes the original article or study. The main content provides the critique or additional insight and supported by evidence or data. The conclusion summarized the main point and suggested further research or consideration. The closing, a polite sign-off with the author's name, title, affiliation, and contact information. The example illustrates how to structure a letter or to address a specific article, providing a constructive feedback and suggesting area for further investigation. Well, now to the beautiful part of the presentation. There are some tools that can aid you in writing any type of letter. And in this example, we talked about the letter to the editor. These are examples of AI websites that you can use. We are going to work with AppTexta AI. I'm finding a problem with simplified.com in mobile, but it worked fine in computer. Can you see the screen?
Yes, we can.
Thank you. Okay, let's give an example of email or letter. Get started. Here we can see the startup, set up your AI-powered letter writer. Please be more specific. It helps to personalize your AI assistant to meet your needs. Describing the letter. Let's try it. Okay, this is an example. We're going to remove. Let's say write a letter. Okay. To the editor. Let's say complementing and complementing the Geriatric research program and talk about the successful projects or its successful projects. We can determine if the tone should be friendly or not. It should be descriptive in the style. Non-profit organization, let's say continue. Should write a letter. Okay. Writing assistant, create more. Okay, so you have been use 0% of your available credit. I don't know what's the problem. Letter generator. Thank you for your donation. Okay. There's a problem here. Let's get back. Letter generator. We want an email or letter. Let's say letter to the editor. To editor. I'm finding a problem with this keyboard. Complementing. The Geriatric research program. Let's send it here. Okay, enter. Level of creativity, full. Okay, let's say continue. Create. You have no credit remaining. I think it needs a subscription. Let's try Gemini instead. Still an AI that can write our letter. Let's write it here. Write. Okay, write. Okay, here's an example. Dear editor, I'm writing to express my sincere appreciation for the involvement for the innovative geriatric research program that has been implemented in our community. This initiative is a testament to the commitment of healthcare providers and researchers to improving the quality of life for our elderly population. Well, this is an example of the letter. If we entered an additional information, it should be specific to our program and give proper complementation for the program. But this is an example of how AI can aid you in writing the letter. I'm going to confess that I used AI in most of preparation of this presentation. So AI wins. And our previous presentation by Dr. Moayyed was an example of how applications are making our life easier. Okay. Let's get back to our presentation. This was the last slide. Thank you for being here. Thank you for listening to our presentation. Do you have any questions? Hello? Hello, can you hear me?
Yes, Dr. Khalid, we can hear you.
Thank you. Do you have any questions? Thank you.
All right, thank you so much, Dr. Khalid. I'm just going to give a quick update in regards to the project that the Gray Team 1 is working on right now. So we have two projects going on. The first one is the neurological and cognitive changes in adult post-COVID. And the second project is the vitamin D supplementation in prevention and treatment of TB in children and adults. Both studies are systematic review, and we are taking the charisma flow. And currently, with the first project, we did a couple of searches, and we looked into different databases. So the first, we looked into 5 different databases after finalizing the research question. So we looked into PubMed, Coherence, Web of Science, Google Scholar, and Scoops. And we managed to collect 195 articles so far. So as I mentioned, we're going with the Prisma Flow since it's a systematic review. Our next step is going to be figuring out the inclusion and exclusion criteria. And then depending on that, we are going to be moving forward with the next steps. And that's basically where we're standing in regards to our projects.
Thank you so much, all the presenters. And thank you, Dr. Iman, for the update. And we have two raise their hand. Please go ahead, Dr. MD, and followed by Dr. Sabri.
Thank you, Dr. Nadir, and panelist and presenter today. Me and Dr. Ahmed, we just joined like less than a month now. Today we are like interested on hypertension presentation. We work at Colorado Kidney Care Research Office, and we have like 3 pharmaceutical company now running research about primary hypertension and the role of aldosterone dysregulation in the primary hypertension. We would like to have presentation about that topics on the coming weeks, maybe the if there is any time spot for next week or the week after, because we thinking that it's make like now it's two big pharmaceutical company, one running through the AstraZeneca and one runs through the PI. Both of them developing PI about aldosterone synthase inhibitor, and they think that most probably the cause of the primary hypertension because they found in the general population with idiopathic hypertension, they have kind of aldosterone dysregulation. So yeah, if we have the chance to do that, we would be happy and appreciate it. The second also, me and Dr. Ahmed, we are working on research project about the relation between the mortality, increasing the mortality rate here at Colorado population due to alcohol related causes. We now on the stage of gathering the data. I think Dr. Ahmed Usman, he can give more about that. We appreciate if we have some can help us with like its analysis and how to publish that. Thank you.
Thank you so much. And you can email me about the first topic about the antihypertensive medication, so we can include it in some of the coming meetings. I will add it to some of the agenda in the future. Thank you. And some of the seniors, maybe they can join you in your team to help with data and analysis and writing if it's abstract or manuscript. Whoever interested, they can contact you or Dr. Ahmed. Thank you. Go ahead, Dr. Sabri.
Yes, hello everyone. Thank you so much, Dr. Nader. Thank you all for the great presentation today. I just wanted to give you an update regarding our project, which is accepted in the American College of Physicians Saudi chapter here that will be held in Riyadh from 5th to 7th of September. And yeah, we have received the confirmation of acceptance of our abstract. The first author is Isra Tayyib, and the second author is Lina, but I think unfortunately they have another commitment, so they couldn't be able to join the meeting today.
First of all, thank you so much for sharing and congratulations. This is great. So good job, all the team who work on this project. So great. Thank you.
Yes, thank you very much.
Excellent work. Dr. Nihal, go ahead.
Hello, Dr. Nader. Hello, everyone. I have an update regarding two abstracts. I was involved in them. The first one, I am the primary author of it. It was accepted in NAPCRG conference. That will be held in next November in Canada. And the second one, it was a literature review. It was accepted also in the NAPCRG conference. I worked with a lot of fellows from them, Dr. Namarak, Dr. Ashok, Dr. Ala, Wafa, Nosiba, Lina, Dr. Faiza. And regarding the other project, the literature review, it was accepted also, and I worked with fellows like Dr. Sayed, Dr. Faiza, Israel Tayyib, Dr. Lina, Dr. Saida, Dr. Mai, Dr. Hannah, and of course, thank you, Dr. Nader, for giving us the opportunity for that. And these are great news I would like to share with you.
Thank you so much, Dr. Nihar, for sharing this good news also, and congratulations to you and your team members. 2 projects. It's a big deal also. So
Thank you so much for giving us the opportunity, Dr. Nader.
thank you. You did the work. Any other updates? So I'm gonna just so this is just like a summary of what we did as teams. So there are several research projects were going on, as Dr. Sabri and Dr. Nihal mentioned. So we have NAPCRG, which is stand for the National North America Primary Care Research Group, that involving primary care physicians here in the US and in Canada, and maybe the Mexico, but this is where they meet in different cities every year. So this time they will meet in Quebec and Canada. And we have 2 abstracts, one of them titled The Effect of Vitamin D Supplement and Low Back Pain. And this is the second one, examining the role of artificial intelligence. And we have the oral health and its effect of cognition by Dr. Isra and her team, that will be presented in Saudi Arabia. The other one, which is Dr. Faiza and her group, also submitted this social isolation among refugees in challenging factor. Is a challenging factor in managing depression case report, that will be also presented at the Arab Health Summit, that will be in Detroit area in October, I think. And the last one is submitted to the GSA, and this was titled Genetics and Serological Biomarkers as Predictors of Parkinson's Disease Cognitive Impairment. This is a systematic review abstract that was submitted. And here the list of the authors, and hopefully we will hear the good news from them, just to summarize and update you guys. Great work, all of you. I'm very glad for you. Congratulations to all teams. And Dr. Seda, go ahead. Or go ahead. You are muted. Dr. Seda? Okay, Seda. Let's try again, Dr. Seda. So try to unmute. So there's many congratulations to the teams. For some reason, Dr. Seda has technical issues with the voice. Can you type it? Maybe we can just read your chat. Any updates or any other questions, suggestions, ideas? Please feel free to share.
Yeah, Dr. Nader, thank you. I just wanted to ask you if we can use our affiliation as a Geriatric Research Fellows in that conference.
Yes, but we are now trying to get the telegeriatric under the foundation. It's called the Combined Research Foundation. So we will get some support from that organization. So you can put the affiliation as the telegeriatric research program, a fellowship program.
Okay. Okay, thank you.
You're welcome. So Dr. Saida, I think she added one more. Okay, I'm gonna just share the screen. So the American Academy of Pediatric also, we have another abstract that was submitted and accepted. So it will be presented in September, end of September. So congratulations to the team. Thank you so much for sharing. And the title for that was The Impact of COVID-19 Pandemic on Precocious Puberty, a Systematic Review. And these are the presenters. Congratulations to all of you, and great job. Thank you, Dr. Saida and your team.
Thank you, Dr. Nader. I'm sorry for having that technical issue. I just want to update you regarding our abstract because I can't see anyone from the team. So it was a great work to have that submitted and accepted by American Academy of Pediatrics, and it will be presented by Dr. Mafaz, as you said, on September 29th. So it was a great work, and we are looking forward to have another work. And we are currently actually working on with Dr. Alina. We are working on the effectiveness, a project called Effectiveness of Smoking Cessation through Applications. So we are just starting from the scratch, and just Dr. Alina posted in the chat, we need someone expert to guide us through the process. It will be a systematic review. So yeah, we have some experience, but we need someone like expert, and we can always return to you as we know. And thank you so much.
Thank you again for sharing. And someone raised his or her hand, but congratulations to you and your team. This is great. Regarding the smoking cessation and the mobile app or the technology, maybe one of the seniors or some of the seniors can help those who did the systematic review. Maybe Dr. Nihal, are you there? Some might have an idea just to help you with the steps as far as how to do the systematic review and see how it's done. Dr. Alina,
Yeah,
go ahead.
Doctor. Okay.
Yeah, hi, Dr. Nadir. Thank you for having me today. So I want to join Dr. Rawai, because we were trying to create a group and we succeeded in this. But unfortunately, right now we search for the data, and it looks like there is not enough information about all the apps I sent you email about. So I'm not quite sure we will proceed with the whole idea, but maybe we can, transform the idea and create a little bit different questions. So, but we are still looking for someone who might help us with the project, because we are ready to work and really want to work hard, but we just need some help with navigation. Yeah, thank you so much.
Sounds good. So perhaps Dr. Nihal, maybe you can jump in.
Yeah, doctor, of course, I have the ability to help anyone with the steps of the systematic review, and also all the members of my team are ready for that. So if anyone have a question, can message me on WhatsApp.
Sounds good. So you can work together. Excellent. So Alina, you can tweak the title or the research question. It can be a mini review, or you can submit it as an article, or even just an abstract about what's available in the literature to summarize that. So great job. Thank you. Thanks for sharing. Anyone else? Dr. Nihal, if you can add your phone number in the chat, Dr. Elena will contact you. Please and thank you.
Sure, doctor. Okay.
Any other questions? Any other ideas, suggestions, notes?
No, Dr. Nadal. I just submit
Your voice a little bit far. Can you
yeah, I'm sorry about that. I just want tell you that inshallah it will be accepted. We just submit our abstract regarding the impact of the gut microbiota and the immune reconstitution and the graft-versus-host disease in post-bone marrow transplant in children. My question is the affiliation. Do we have? I just put Geriatric research fellowship at Michigan State University. Is that okay, or I have to?
No, just the Geriatric research fellowship program. That's it.
Okay.
You don't have to add any more. Michigan State University. Just leave it out.
Okay. Thank you very much. Thank you.
You're welcome.
Do you think they will ask? I just emailed them again, and they said that there is any other document or something like that they have to submit it with the abstract. Do you think I have to submit any? I mean, during when I did the process, it doesn't ask for any it's not necessary to write the name of the college or whatever. So it goes smooth actually, and I hope inshallah they will accept it. But just I'm wondering about if they go over from where who are we or something like that, what they have to say.
So if it's a conference, usually they don't ask very specifically requirement as far as you go with the school or institutions. Some of the company, they can create their own abstract and submit it and get accepted. So they are not affiliated with institutions. So this is not a requirement unless they very specifically are related. Let's say here in MSU, they want their students to present. So this is just for
that's what I understand.
They want you to, if you have some affiliation, they want to show that there are some contribution from other institutions for the conference. So it will show better when they write their grants in the future that we have 10 institutions or something.
Yeah, because as you remember that when we try to put it at ASH, they make it a little bit complicated. They need membership and they takes time from us. But now after Dr. Mabas submit her abstract about the eosinophilic esophagitis. It's for the American Association for Immunology and Asthma and Immunology. So we found that we could submit our abstract, the other abstract about the microbiota and the immune reconstitution as well. So we just go ahead and we did it in the last day. So I hope they will accept it without asking for details about the college or these things.
Yeah, hopefully you will get the good news. So that's great that you submit it, and I wish you all the best. This is good.
Thank you. Thank you very much. Thank you.
Thank you. So I'm going to just share with you here the in the chat. I shared with you guys the website for the Combined Research Foundation. So it's based here in Michigan. We started that and we are working on getting it. So it's registered in the US. and we are trying to get it like non-profit accepting donation. Currently, we can get donation, so any one of you can donate. Hit donate. Just it shouldn't be a big of money, just $5-10. We can start with slow, and then the goal is to write grants for some of the organizations that support all medical or dental or any healthcare education, as well as improvement with the healthcare workforce in the future. So we can get some funding. I am talking to different groups, and we are just waiting to establish the status with the IRS to accept donation, and it will be under tax deduction for the people who donate in the future, or we can get donation from big organizations to support the program. In the future, we may have some opportunity for like training, workshops, or actual hands-on. So we will have simulated patients for you, for example, geriatric cases. So you will come to a center where you can do your history taking examination, plan assessment, and so forth. And you will be recognized for that. It might be a clinical experience here in the US, and you compare what you do like back home if you are from overseas, for example. So all this we are trying to build step by step, but we want to start with the government first to be recognized as the Geriatric by itself. It's part of a bigger foundation, the Combined Research Foundation. So if you want some information, this is a website. I shared it with you. If you think you want to add any content to the website, this is just a scratch. You can go down and add your info. If you don't like the home page, for example, we wrote just a brief background mission. So you can go down and just add your comment. I want to add this, that, the conferences and so forth. So we'll try to get everything updated. So far, we are lagging behind with some of the data that we have, but hopefully we will get this in a newer version. This is just to be on the web for people to be validating what we are doing. In case you have a letter of recommendation, they talk to you about Geriatric, you tell them yes, and this is a website. They can go here, they can find our contact information and so forth. This is just one thing we can work together. If you want to help, that would be great. Just add any comments that you think we can add to the website. Any new ideas, we will just incorporate these ideas as well. So I wish you all the best. I know nowadays you are working hard on your application for ERAS and the residency, and I'm working on getting you the recommendation letters uploaded to the website. So if you in the coming days you don't see your letter uploaded, please contact me and give me your name and maybe the AMC ID or the letter ID request, and make sure you add some of the activities in the app where I can look at what you did, and so that I can personalize the letter for you guys. With that, I just want to thank all of you. Any further questions? If not, I'd like to thank you so much, Dr. Iman and your team. I'd like to thank all the presenters from today. They had good presentation, excellent ones. So I'm very happy with you guys, and thank you all for attending. I know we have more than 50 today, so thank you. And for those who are coming later, and you can review the recording. Thank you in advance for that. I wish you all the best and have a wonderful day or night. See you next week. Assalamu alaikum.
Assalamu alaikum. Thank you, Dr. Nader.
Alaikum salam.
Thank you, Dr. Nader.
Thank you, doctor. Appreciate your help.
Anytime. Thank you.
Thank you, Dr.
Thank you.
Nader.
Thank you. Assalamu alaikum.
Assalamu alaikum.